So let's make a start. Welcome everyone to this, the 19th meeting of the Public-Audit-Committee. In this session we have apologies from Tavish Scott, not from anyone else. Could I ask everyone to make sure their phones are off, please? First item we have is a decision on taking business in private. This relates to item 4. Looking at how we take forward the Audit Scotland report on NHS inequalities. Is the committee agreed that we take item 4 in private?
Agreed.
Thank you very much. We'll move to item 2, the first substantial item on our agenda today, which is the Section 23 report. This is a joint Auditor General and Accounts Commission report on health inequalities in Scotland. Welcome the Auditor General for Scotland, along with our colleagues Claire Sweeney, Portfolio Manager, and Phil Grigor, the Project Manager of Performance Audit Group, all from Audit Scotland, and invite the Auditor General to introduce this report.
Thank you, Convener. Scotland's health inequalities are long-standing, complex and difficult to solve. And addressing that problem requires a range of public bodies to work together. It's not just the responsibility of health services. What we've done in this report is to look at how public bodies work together to target their resources at those most in need, and to what extent they're monitoring their collective performance. We found that there have been long-term increases in average life expectancy and major improvements in overall health in Scotland, but there are still major differences among different groups of people. Deprivation is the key determinant of health inequalities, although age, gender and ethnicity are also factors. People in Scotland are living longer, but average life expectancy remains lower than in other parts of the UK. Men living in the most affluent areas of Scotland live on average around 11 years longer than those living in the most deprived areas. The corresponding difference for women is around 7.5 years. For average healthy life expectancy, the number of years that people can expect to live in good health, the gap between the most deprived and the most affluent areas is even wider at around 18 years. People in more deprived areas also have higher rates of coronary heart disease, mental health problems, obesity, alcohol and drug misuse problems, diabetes and some types of cancer. Children in deprived areas have significantly worse health than those in more affluent areas. For example, they have lower average birth weights and breastfeeding rates, poorer dental health, and are more likely to be obese. Reducing health inequalities has been a priority for successive governments in Scotland, but most indicators show that inequalities are not reducing. We looked at how much money is spent on tackling inequalities and what we get for that money. The Scottish Government takes account of local needs, including deprivation, in the formulae that it uses to allocate funding to NHS boards and councils, but it's not clear how NHS boards and councils then allocate resources to target local areas with the greatest needs within their overall areas. It's difficult to track spend by the NHS and councils on health inequalities. The Scottish Government allocated around £170 million to NHS boards in 2011-12 directly to address health-related issues associated with inequalities, including around £15 million for the Keep Well programme, which delivers health checks to over 40s, and the Child Smile Dental Health programme, both specifically aimed at reducing health inequalities by targeting particular groups within the population. Primary care has got a particularly important role to play in helping to reduce health inequalities, and the distribution of some primary care services, such as dentists and community pharmacies, reflects higher levels of need in more deprived areas. But for GPs, who for most people are the first point of contact with healthcare services, the distribution doesn't fully reflect the levels of ill health in more deprived areas. People in more deprived areas also tend to have poorer access to hospital services, receive fewer treatments, have worse outcomes, and are more likely to miss appointments. We looked at the arrangements for tackling inequalities, and we think there's some room for improvement there as well. Many organisations are involved in trying to tackle health inequalities locally, including health boards, councils, community planning partnerships, voluntary organisations, and general practices. This means that coordinating effort well is essential, and community planning partnerships need to ensure that all the local organisations, not just health boards, understand their responsibilities in tackling the problem. Successive governments have introduced a range of strategies which aim to improve health and reduce inequalities. It's clear that measuring the success of these is difficult because many interventions are long-term, often taking a generation or longer before you can see significant improvements. But measures of short and medium-term improvements are also needed to demonstrate progress and ensure that the actions being taken are having the desired effects. Some local initiatives have been effective in reducing health inequalities, but most have lacked a clear focus on cost effectiveness and outcome measures. This means that assessing value for money is difficult. The range of performance measurements and reporting arrangements relating to health inequalities makes it difficult to establish a clear picture of progress. In particular, community planning partnerships reports on delivering their single outcome agreements are weak in the quality and range of evidence they use to track progress in reducing health inequalities, so that a Scotland-wide picture is hard to identify. Convener, our report contains a number of recommendations targeted at the health service, at community planning partnerships and at the government to move this picture forward. And my colleagues and I will do our best to answer any questions you and your colleagues on the committee may have.
Thanks very much. Maybe I could kick off with a question from the introductory background. I think everyone would be most concerned about the human cost of statistics like the disparity in life expectancy, but in paragraph 4 you also identify an economic cost to these health inequalities, and the figures are really quite startling. You say if the death rate in the most deprived groups in Scotland improved, then the estimated average economic gains would be around £10 billion at 2002 prices. And if the death rate across the whole population fell to the level in the least deprived areas, the estimated economic benefit would exceed £20 billion. These are huge figures, and I just wondered how you arrive at these figures for the economic loss or the economic cost of health inequalities.
As you say, Convener, all of us will be concerned about the human cost, but they are staggering numbers. They're derived from the influential Marmot Review on health inequalities that was published in 2010, and I'll ask Phil Grigor, who's our expert on this, to talk you through how we derived an estimate for Scotland from that.
These are pro rata comparisons with the figures produced for the Marmot Review. The comparisons of the 10 and 20 billion for improving life expectancy are based on a concept called the value of statistical life, which is the amount that society is willing to pay for the cost of saving lives. This is a conservative estimate, though, because it doesn't include actual health improvements, and there's a separate estimate done for the Marmot Review which estimated to be an extra £60 billion UK-wide for improving the health of the population based on taxes, productivity, lower health care costs and that kind of thing. So the pro rata comparison for Scotland would be an extra £6 billion.
So the real figure is likely to be £26 billion
This
in
is
economic cost.
The £10 billion is at the lower end of the estimate, and the 20 was the higher estimate, but the paper that was produced for the Marmot Review said that these are likely to be very conservative estimates.
But you said there that there's a further £6 billion, yes, which isn't included in the 20. So actually, it could be looking at as much as 26 or £30 billion of economic cost.
Based on the pro rata comparisons with the Marmot Review, that would be the figure, yes.
Okay, thanks very much. The other question I wanted to ask was about what's happened over time. The report does look at the economic inputs that are made to try and deal with this, and there are two figures which I'll come back to, but the thing which struck me was what direct funding to try and address the health inequalities is actually spent on. And the report makes the point that these are inequalities which have persisted really for perhaps 50 years. And I was struck that one of the inputs was the Child Smile programme. Now, I can remember being in the Happy Smile Club 50 years ago. In fact, I rather fear that my mother could probably still find my Happy Smile Club badge. And my question really is, if we've known about these inequalities for as much as 50 years, certainly for the last 10, 15 years, And if for the last 10 or 15 years, administrations of different political stripes have said that this is a priority, have we actually increased the investment we're making? Have we really changed at all what we're doing in order to try and address them? So, for example, if we look at Exhibit 11, which tracks total funding allocated not just through the health service, but through other initiatives to do with things like fuel poverty, there are 3 years of figures there which run from £586 million to £607 million, and that's from 08-09 to 10-11. That looks to me like a real terms decrease, actually, over the piece, perhaps marginally. Slight cash increase, but over those 3 years, I think, with the deflator, that would be a real terms decrease. You have another figure in the report, £167 million, which I think is money spent in the health service in a single year. So my question is, were you able to find any evidence at all that targeted spending to try and address these inequalities is increasing or decreasing or just staying the same?
You're absolutely right that these are very long-standing problems and that they have been a priority for successive governments. One of the main things we found, I think, is that it is very hard to be clear what's spent on tackling exactly that problem. A range of things happening. One, I think it's become clearer over the last couple of decades just how important inequality is in terms of deprivation in leading to and contributing to health inequalities. So that focus has started to sharpen over time. But it's also clear that the amount of money spent on health services, which has been our primary focus in this report, needs to be targeted on the people who are most at risk, people who are deprived, who are suffering ill health, both in terms of prevention over time, which is government policy and is absolutely right in terms of the long-term benefit, but also in terms of tackling the health problems that people have at the moment and for the foreseeable future, which are also a real and present problem. And what we've found is that actually it's very difficult to track what money is being spent on tackling those problems out of the nearly 12 billion that's spent on the health service as a whole. That's true once you get to an individual health board or council. It's very hard to tell who's using both health and social care services in terms of which communities they're coming from and how much deprivation they're facing, and in terms of what's happening with primary care services. We've done what we can to draw that out in the report for you, but really the finding is that it's not clear how that resource is being targeted, and that targeting is critical to tackling inequalities. We know that if you spend more overall, what tends to happen is that more affluent people are better able to access services and get more benefit from them. So although you get an overall gain in health, you probably get an increase in inequality at the same time. So
if my question was, over time, whether that's 10 or 15 years or maybe even a longer period, have successive administrations skewed spend to target it to try and address these health inequalities? Your answer is, we can't tell. Is that fair?
That's the closest we can get. We've given you the information that we have been able to pull together here, both in terms of special initiatives, which is what you're seeing on Exhibits 10 and 11, and in terms of the allocation of mainstream health services, and it's not possible to see what the long-term shift is, although there has been a significant investment by successive governments since the Parliament was established.
Thanks very much.
Thank you. I just really want to try and get to the heart of the matter, because this is nothing new. When we came here in 1999, since 1999, I've been 8 years on the Health Committee, and health inequalities was at the centre of the agenda for all the times I was on it, and I'm quite sure it's when I've not been on it and since. But I'm looking at the figures now, and they're no better, despite everything and all the good intentions. And I would just like to run through one or two points first, and that's the comparison between the most and least deprived. I think over twice as many GP consultations for anxiety, that worried me, 4 times higher smoking rates, 8 times more alcohol-related hospital admissions, 5 times more teenage pregnancies, and the life expectancy average 11 years is the same as it was in 1999. Obesity and dental health are poorer. Alcohol liver disease has increased 5-fold. Alcohol deaths trebled, and drug-related hospital discharges 16 times greater in deprived areas. And yet, the Arbuthnot formula and the NIRAC formulas have all taken account of deprivation, I'm quite sure. There's around 40% more GPs in deprived areas. There's about twice as many dentists with the 9,000 additional allowance. There's more than twice as many pharmacies. There's higher QOF payments for long-term conditions in deprived areas. 170 million spent last year, and yet we don't know where the money's going. We don't know how it's being spent. We don't know if it's being targeted to those in greatest need. And I quote from the report, policies and strategies to reduce health inequalities have so far shown limited evidence of impact. So in 13 years of this Parliament, with an intention across all parties, where are we going wrong?
I think there's a couple of important points to make on the range of issues that you raise there. The first is that we know that the inequalities in health are not only the responsibility of the health service. They are affected by a range of other things, including deprivation and poverty, as we say in the report, and the wider economic and social context that we're working in will have had an impact on some of the health problems that you ran through in your list of indicators there. One of the real challenges is that when the health service and other public services focus on those problems, unless they're very careful to target the interventions they're making and the money they're spending on the people most in need, you tend to get an effect where everybody moves up a little bit, but people who are more affluent gain more benefits, so actually the gap is rising rather than closing. And that's why this is such a tricky problem to tackle, I think. A targeted approach is very important in terms of the health service and the wider public services that are needed to tackle health inequalities. And as we say in the report, one of the challenges is that we don't know to what extent most of the 11.7 billion spent on the NHS last year and social care spending by councils is targeted on the people who have the most significant needs and the biggest health problems. We're recommending that should change, that there should be more tracking of who's using health services and a better understanding of the barriers to their use of services. At the moment, we don't have that. We just know that although, for example, life expectancy is increasing for all of us, the gap is still increasing, as you can see in the charts in the report.
Could I just raise 2 points from that? When Humza Yousaf and I visited the Drumchapel Centre, I found that very, very interesting. And of all the people that we spoke to and all the people that gave their evidence, no one said we need more doctors. But what they did say was we need a better understanding of housing, deprivation, poverty. And what they were saying is they've got so many worries and concerns that they couldn't concentrate on trying to look for a healthy lifestyle because there were so many other worries. And to me, the GP consultations for anxiety twice as high, is that not just a call for help, and is that being listened to? And I don't want to stray from the audit thing, but to me that is the core figure. And if I could just look at paragraph 49, and you did mention this in your opening statement, over 20% fewer cardiology treatments than expected, while those from the least deprived areas received over 60% more treatments than expected, and people from more deprived areas may have lower rates of treatment because they're less likely to reach hospital alive following a heart attack. I mean, there's something going far wrong there, and we did take evidence on that in Glasgow, but it's almost blaming people in deprived areas for, it's all your fault. You're not getting to the hospital quick enough. You're not recognising when you're having a heart attack. I mean, that can't be the way forward, surely.
Absolutely not, and it's certainly not our intention to be blaming poor people for it.
Yes.
I think I'll ask Claire to come in a moment, but I think what we're saying is that, yes, health inequalities are a big problem that is not the responsibility only of the health service. All public services, the third sector and people themselves have got a role to play in improving inequalities and taking this big problem forward. What we are saying, though, is that the health service has to be at the heart of doing some of that, and particularly primary care, I think. GPs are often the first port of call for people, and I think you're right. Things like consultations for anxiety and depression can often be a signal that there are wider problems that need to be addressed. There has been a lot of investment in things like the Keep Well programme, and particularly the deep end practices. And what we heard in talking to GPs in those areas is that often they feel they don't have enough time to spend with patients to properly understand what's going on, and they don't have the networks into other public services that would help them start to tackle some of those problems. So there's an important starting point there, and some good investment, some good work that's been going on, but certainly room to take it further and to make sure it really is targeted on those most difficult problems. Claire, do you want to pick that up?
A couple of points to raise there, I think. When we were carrying out the field work for the audit, we found some very good examples of local working. So I think we wanted to highlight that in the report as well. That we've seen some good examples of partners coming together in the widest sense, or people from housing, police, the NHS, the local authorities, sitting together and working out actually who are the people in our local community that we really need to provide more support to, and do that on a collective basis. So that's very encouraging. The other thing that came through quite strongly, though, was the disconnect between some of that good practice, some of that encouraging work at a local level for communities, and how that was tied into funding, planning for services. So although sometimes there was evidence that things were making a difference, does that actually relate very strongly to where the funding goes? So if they're putting in bids for resources for the local area, actually is that listened to? Do people take that on board as a priority? So I think there's an important point there. The other issue to mention is the important role of the community planning partnerships that we've drawn out in the report. They have a lead role around this agenda, and I think it's very important that they have a very clear idea of priorities in terms of developing their approach to health inequalities collectively, and also that they've got some clear measures in place to see that they are making a difference, to check that the investments that they're making around this area are actually leading to improvements for local people. That came through very strongly from our local work.
To be fair, we've had evidence of good practice for 13 years, and a lot of these are pilot programmes, and they tick the box and say, haven't you done well, your 3-year funding's finished, we'll now go back to where we were. But I have to be honest, I find it really disappointing. No evidence to date that targeted national programmes have helped reduce health inequalities. Equally well, we also look at Appendix 3, no impact of improvement there. And if I could just give you one small thing, which I don't think is rocket science, and you know, the one thing that deprived areas have is more than twice as many pharmacies. Now they can at least help the 4 times more people that are smoking in these areas. And yet, there's no join up between the pharmacy and the GP. What we're told here is a pharmacist undertaking a health check as part of a community-based intervention, paragraph 62, is not able to email information to a GP. The information has to be printed off and physically taken to the GP surgery because there's no secure email. This creates more work for the pharmacist and gives them little incentive to continue to carry out health checks. So you've got twice as many pharmacists, but there's no point in them doing anything because they're not even, in this century, they're not even connected to the GP. We can't even do that. They have to get out on their bike and go around the corner and hand it into the GP. So, I mean, what we are seeing here is just barriers and barriers and barriers. And for 13 years, we've been listening to, should be better partnership working. And we're actually hearing the same today as we heard about the lack of partnership working in 1999. And that has not been as a result of a lack of political will from any party. So what needs to be done about that? I mean, this is a nonsense here. No incentive for pharmacists, and yet they seem to be on every street corner. I can't even get a secure email.
I agree with you. It's a great example of the sorts of targeted changes that need to happen to make a reality of this. I think there is no doubt about the commitment of successive governments to tackling health inequalities. We have seen significant investment going in. What we're saying is that the importance is to really target that at the communities where it is most needed, and that's at a very local level. We give the example within Glasgow, within Shettleston Ward, of how localised problems can be, and then focusing within that area, as Claire said, by working with the GP practice, the CHP, the Community Planning Partnership, to agree exactly how those barriers need to be taken away. In that case, obviously, secure email is important. None of us wants our personal healthcare information being handled insecurely, but it should be a straightforward thing to fix with that very focused attention to the particular problem.
If I could just finish by going back to the point the convener made and you made in the opening statement. The economic cost of health inequalities is estimated at 26 to 30 billion, and yet we haven't got any money or the will to connect a pharmacist to a GP. I mean, that's not good.
That's a statement, probably.
A statement, sorry, but I thought it was worth relating back for the cost of making a successful intervention against the opportunity cost.
Okay, thank you very much. Scanlon, Ms White.
Thank you very much, Convener. Good morning. Thank you very much for the report. I think it's an excellent report. Obviously, we've touched on areas of inequalities in health, and it's one of the ones that I want to catch up on. I raised it to the last committee meeting about the deep end practices and was absolutely shocked. I think that was part of what I said in the report, that of the 100, 86 of them are in Glasgow, and that's very, very worrying. And I take the point that you made in your opening remarks about deprivation is the key, and it is about people working together. And I must say to Mary Scanlon, you know, the policies coming out of the Conservative Westminster government is certainly not going to make it. It has got a lot to do with it, Mary. If you're being put out of your house and welfare benefits are being cut, I would think people who live in the most deprived areas are going to have even more of a shocking time. And I just want to put that on the record. I think there's some improvement, as you said earlier, regarding the health, and that's to be welcomed. But obviously there's a lot of work to be done, particularly in the deprived areas. And I was interested in the page, is it page 19, about the health inequalities. And I pick up on the figures that the convener read out. Page 19, it's Exhibit 11, about the money that's been targeted to help the inequalities. We've got 08-09, 568.5 million, 09-10, 595.95 million, 10-11, 607.30 million total, funding has been allocated to look at these particular areas. Now, would you say that the reason it isn't working, although the money has went up in that respect, is because there's a lack of partnership working, particularly with CHPPs? And I pick up Mary's point about the pharmacies. I certainly know in my area, in Kelvin, there's a number of pharmacies work very closely with doctors and hospitals, but because of data protection that's been put forward by the NHS boards, they're not allowed to email, unfortunately, but they would love to do it, and I do pick up on that point, something we should look at. Would you say it's the lack of partnership working which is not reaching these deep-end practices?
There's a great quote in a letter from Dr. Graham Watt to the Herald last week when the report was published, which is saying that where the need is greatest is where we need the NHS to be at its best. And I think one of the challenges in areas like the deep end practices is that it's not just that health need is greatest, it's that every other type of need is greatest as well. Housing, education, all of those things are difficult for people living in those communities for reasons we all understand. I'll ask Claire to pick up again some of the specific things that we've seen that we think could make an improvement. But I'll stress again, because I think it's so important, that for me, one of the critical things about reducing inequalities is really being able to target in at quite a local area and look at what the specific problems are there and to build ways of working that improve it. There are some practices where secure email is in place, where community pharmacists can have access to patients' records with consent and can take on a lot lot of the work that can be done in a community setting very close to people's homes. In other places, that's still a barrier. We need to understand better what's needed to shift those barriers and the equivalents in other places, because they will be different. Claire, can you pick up?
Yes, when we talk about partnership working in this context, and in any context indeed, what we're not talking about is a sort of vague general concept or something that would be just a good thing to do. It's about being very clear about why the partnership's coming together. So for some things, the partnership might need to agree that actually the police or housing would be just as good as doing something on their own, delivering something on their own. It's agreeing as a partnership what bits you can only really achieve together, and being very focused around that, because it is time consuming and it does take a lot of effort. I think one of the big things from the report is about the need for performance measures and assessment of what's making a difference, and tracking the difference that the investment is making. When we talk to people out in the frontline services, they told us that it was very, very difficult, and we accept that. It's very difficult. They're working very hard to try and improve this at a very local level. But they often told us the reasons things couldn't be monitored, couldn't be measured. But actually what they were describing as auditors, we saw, yes, you can actually. There are things that are very tangible, short-term, medium-term, yes, long-term changes that need to be made. But you can see that happen. You can demonstrate that some of these things are making a difference. So I think for us it's having a much keener eye about how that needs to be taken forward at a local level. I also think there's something quite interesting about this message around partnership working and the intent and the commitment from people. And I think what we saw was a real commitment at a very high level. This is very important for Scotland. People signed up to that. It needs to improve. People at frontline dealing with this day in and day out, really struggling very hard to try and move that forward. But I think something maybe interesting about how that's connected up. You know, what is it that's stopping that working? Is there something in the middle that means that's not being delivered as effectively as it might do? It's always going to be hard, but we saw that there was definitely cases where things could be improved.
Chair, sorry, can I follow up? Thank you very much. And I do take on board the pharmacy working, because certainly certain pharmacies, Reach Pharmacy and others in the Kelvin constituency, do work very closely with doctors, and they seem to have their act together, as you might say. In page 19, paragraph 36, I just wanted to pick up on what you're saying about basically, tracking what happens and outputs. In paragraph 36, you mentioned GP practices in Scotland received around 134 million in QOF payments, basically. And you go on to say there's evidence that it has helped to reduce the gap between the most and the least deprived areas in the management of chronic disease. But then you also go on to say it's too early to say whether these improvements in management practices have led to reductions in health inequalities. Is that because it's just been set up and we need to look at it in a longer term? Is there other areas where it's been set up previously that we haven't tracked?
I think it's a good example of what Claire was just talking about, that we all hope that that investment will help to improve the health of the poorest people, those who are most deprived in the long term, but it's too soon to see that because of how long it takes. What we can see is that it's improving the targeting of the management of people with some chronic diseases. So that's a good sort of interim measure that you would expect to lead to a narrowing of the gap in the longer term, but it's too long to see that longer gap. Claire, is that fair?
That's right, and I think some of the initiatives around GP practices when the new JMS contract was introduced were about getting lists and registers set up so people could actually see what they were dealing with in a sense. So it's a case of moving on from that now. Actually, we know some of the things that can make a difference. We now have a better feel for the populations we're dealing with, so what do we do next? So it's almost a kind of step process in terms of the GP contract, I think.
Thank you. Thank you.
Thanks, Mr Griffin. I think it has a supplementary.
Just a supplementary on the point of the QOF payment. You've stated that it does have the potential to reduce health inequalities, but not explicitly designed to do that. Do you think it would be an appropriate recommendation within the report to ask that the QOF, one of the outcomes are specifically to address health inequalities?
I think it's already happening. It's maybe something you want to pick up with the panel from the Scottish Government following us. But we know, for example, that in the recent negotiations on the GP contract, there has been an agreement to make some shifts to the indicators which can be used to target inequalities further. And it's something that I know is very much in the minds of the government in negotiating the contract and the quality and outcomes framework with GPs in Scotland specifically.
very much. It is Christmas and I'm instinctively generous, but colleagues need to try and keep the balance of their contributions towards questions, or we're going to miss Christmas lunch today, which I believe the canteen is offering. Mr. Britier.
Thank you, Vera. I was actually quite curious about the improving of life expectancy and the expected savings around that. For some reason, I had in the back of my mind that if you actually took into account the totality of pension liabilities and so on, it actually costs more money for people to live longer. And I take on board the information you gave, but does your calculation actually take into account pension liabilities and so on? I'm not saying this is a reason why we shouldn't improve life expectancy, but I'm just curious to see the figures behind it.
This is based on the cost-benefit analysis of introducing a public policy, and obviously it's going to cost money to pay out more pensions, as you say, but there's also a benefit there that the people will spend more, live longer, and there's an economic benefit there, and this will be the net benefit of people living longer.
Well, I'm encouraged to hear it. Last meeting, I raised the question of GPs in deprived areas, and what this report does make clear is that while other facilities such as pharmacies and so on are clearly in larger numbers in deprived areas, GPs are not. Now, we've had explanations and so on from the government as to how they calculate it and all the rest of it, but unless I'm mistaken, in absolute terms, there are less GPs in deprived areas, and, you know, would it be that would affect the outcomes in these areas?
We think GPs are a very important part of tackling health inequalities because they're the first port of call for most people with a health problem, and because GPs have got the ability to look right across the person's life, their circumstances, their family and so on, and think through what the real problem might be, given the time and the other support services needed to do that. The challenge, I think, for GPs, particularly for the government in relation to GPs, is that they're independent contractors, so they can't be directed to a particular place in Scotland. What we have seen, though, is that incentives can work. So if you look at the allocation of dentists and pharmacists, there were specific incentives to encourage dentists and pharmacists to set up in more deprived areas, and you can see on the two graphs on the facing page the association is much clearer with deprivation than it is with GPs. It's why we think there is room to go further, in line with Mr Griffin's question, to put incentives into the GP contract to encourage the same sort of pattern. Would you like to add to that, Phil?
Well, I think that's a fair point, that we have shown that the deprivation allowance for GPs that was introduced in 2007 did have an effect. Obviously, they are independent contractors, GPs, we can't force them where to go, but the graph, Exhibit 16, shows the clear impact of introducing the deprived areas allowance for dentists, and if that was introduced for GPs, then that may go some way to closing the gap.
I'm also interested in a theme that goes through this report, which is that there doesn't seem to be clear outcomes, measurement of outcomes. And in this committee, we've in the past discussed that, you know, that very thing, that where statistics don't seem to be there to back things up. But we've got some good statistics in this, and it seems curious that we've got all these statistics, factual statistics here, but we don't have outcomes. Now, have you any thoughts as to why that might be? I mean, we're not seeing, I mean, looking through this report, you don't get a feel as to whether what we're doing is actually right. And you know, I think Mary Scanlon touched on it, that in 13 years, successive administrations think they're doing the right thing by putting the money into this, that and the other, but there seems to be no proof that that is so.
In the long term, the statistics we've got in the report are the outcomes. The problem is that they are long term. They can take a generation to demonstrate whether what we're doing now in terms of targeting services is affecting people's life expectancy, healthy life expectancy, or particular diseases. What we're suggesting is that there's a need for more, for building in more evaluation at the beginning of significant investments like Keep Well and some of the other investments in tackling health inequalities, and particularly there's a need for more short and medium term process measures and impact measures of things moving in the right direction. A good start would be knowing whether hospital services, for example, are reaching people in more deprived communities at the rate we would expect. the evidence in the cardiology report earlier this year suggested in that area specifically that they're not, and we need to understand better why that is, and again what barriers we can get out of the way to do it.
So overall, you would say that although we're not able really to measure these outcomes yet, in time we will be able to. In other words, the measures are in place. It's just a question of literally time to see if we're on the right track.
A question of time and being explicit what it is we're trying to measure. If we don't have a proper framework for evaluating the effectiveness and the cost effectiveness of what we're doing now, life expectancy will continue to change, but we won't know whether it's due to where we're investing money at the moment. It's the broader point, I think, about building in evaluation at the beginning of a policy so that you can track what impact it's having in the medium term as well as over the long term. Claire may have some particular examples just to bring that to life for you.
I think one of the things to mention is the Exhibit 21 in the report, which looks at CPPs and the single outcome agreements. And I think that starts to give you a bit of a picture as to what we mean by a lack of a real clear focus on what we're trying to achieve here, particularly in this instance at a local area. And I think some of the challenges that we've picked up around the way that those single outcome agreements describe the progress and what's intended and the variation in that. And when we've got such big problems that are consistent across a lot of areas in Scotland, you would expect that to be a much more coherent and consistent picture. So I think that's quite a nice example of where we would see that there's a scope to do more and be more focused and more defined about what it is you're trying to do with the resources you have.
Okay. Mr. Scott, I gave your apologies, but like Marley's ghost, you're here.
Yes, rumours on my demise have been greatly exaggerated, I guess, Convener. Thank you very much. Can I just, apologies for missing the early part of your evidence this morning. The GP contract, I wonder if I could ask about that. I think Auditor General, you said earlier on that we should provide, the state should provide more incentives for, or is providing, or should provide more incentives for that. Why should the state put any more money into GPs' pockets?
I don't think I suggested there should be more money put into the contract, and my understanding of the agreement recently reached between the Scottish Government and the BMA in Scotland is that it's about reallocating money within the current total that's spent on the contract. But that's probably a question better directed to the next panel of witnesses. Sure,
but do you think that by any stretch of the imagination the GP contract's working in terms of delivering what the successive administrations have sought to achieve in tackling health inequalities?
I think it is still a work in progress. This report isn't evaluating the GP contract, but we have done some work on that in the past, and I'll ask Claire to come in a moment. As Claire said a moment ago in answer to a question from Mr. Beattie, in the early years of the contract, a lot of the focus was on getting some of the infrastructure in place, like disease registers, like processes for calling people back for testing and screening and so on, where we know it will make a difference. That infrastructure in itself now needs to be used to really direct what GPs and the primary care team do to tackle health inequalities. So there's more that can be done. There is some evidence that it's making a difference, and we make a reference here to improvements in chronic disease management, but there's certainly more that can be done, both in relation to what the primary care team does and to where GPs are located in relation to inequalities.
But I think the government I was part of signed a shockingly bad deal for the taxpayer in terms of the GP contract. And what I'm worried about is that you may be suggesting we should just augment that by giving them more incentives to do what they should be doing anyway.
My focus is very much on incentives within making use of the incentives that are built into the existing contract more effectively in relation to health inequalities. But I think Claire was involved in the last work we did on evaluating the GP contract, so I'll ask her to pick up any points I haven't answered there.
That's right. We looked at how the contract had been implemented in the early stage of getting that contract introduced, so did quite a lot of work a few years back looking specifically at that transition to the new contract. And that report was, I think, 2006 we produced that report. But I think the direction of travel is very much about trying to make more use of things that will actually make a bigger impact in Scotland through the GP contract. And I think Caroline mentioned the changes more recently around negotiations in Scotland and the pattern that that's taken. So we would see that shift away from organisational rewards for changing lists and administrative organisational approaches through the contract and rewards around that to a focus on trying to improve health at a local level is an encouraging thing. So that's definitely the direction of travel.
I think we're just playing at this. I mean, we've been at this, as other colleagues have said, across the committee for 13 years, and frankly, nothing much has got any better. We'll be here in another 13 years, and not much will have got better again. Is the GP contract not at the heart of this in terms of we have a contractor relationship where the GPs can, well, as you said earlier on, are private contractors. We don't have any ability, and by which I mean NHS boards, to control that. They do what they wish and that kind of thing. They can listen to all this guidance, but it's clearly not working, is it?
I think GPs are key to getting this right. I think secondary healthcare is as well. And my sense is that what we don't have is enough detailed information about where the 11.7 billion that was spent on the health service last year is being spent in relation specifically to health inequalities. We're not saying it's easy. It clearly isn't. This is a problem that Scotland's been dealing with for a long time, and other parts of the world are. But it's something where targeting is critical to really understand where the need is greatest and make sure the resources are being focused on tackling health inequality.
So would it be completely unfair, therefore, to conclude that we should, if one was being radical, abolish the way in which we currently pay GPs, instead move to a salaried system, move to a much more, move to a system that effectively the NHS could control and therefore put taxpayers' money into exactly what we're trying to achieve?
I'll have to start with my usual caveat about policy, but I would also say within this report we haven't found at all that the existing GP contract couldn't be used to greater effect to tackle health inequalities. That is the direction of travel, and there's an opportunity to take it further to really make sure we're getting at the people and the interventions that we know make a difference.
Is your argument, therefore, is the Audit Scotland argument that therefore there needs to be much more prescription around what government gets from that GP contract?
I'm not sure prescription is the right phrase. I think it really is about making sure that the incentives are aligned with what we know works in tackling health inequalities and with the communities that we know have got the biggest problems. Targeting in both those ways could be done through the existing contract and is to some extent taking that further and matching it with a wider understanding of how health service resources and public service resources are being used. I think has got a lot of mileage in dealing with this problem.
It could go a lot further than it is at the moment.
It could certainly be used more effectively than it is now. And as I say, I think that is the direction of travel.
Okay. Thank you very much. Thank you.
Mr. Coffey.
Thanks very much. Convener, just as a brief supplementary to that, the approach that we've taken to dentists to incentivise the dental practices in 2006-07, is there an evidence base to show that there have been public health benefits of that incentive scheme?
That's a very good question, and I'll ask Phil if we have any information about the next step. This is one of our sort of interim measures of getting dentists in the right place. I don't know if we've got evidence of impact yet.
Information on oral health is pretty poor. We do have evidence in Exhibit 6 about improvements in child dental health, which have improved across deprivation levels, but they're still markedly poorer amongst the most deprived children in Scotland. And there's in the supplement that we published on the website, there's a detailed breakdown of which children at ages 5 and 11 have met the national standard, and those in the most affluent areas met it quite comfortably, and the national standard was met across the country, but those in the most deprived areas did not meet this national standard. So it may have some impact in terms of improving overall dental health, but those in the most deprived areas are still much worse off.
It's probably a question for the next panel, Convener, because that measure has been in place for some 6 years now, so we can possibly ask the next panel what their views of that are. But I just wanted to open my own remarks and say, of course, that we're indebted, I think, to Audit Scotland for the depth and the rigour of this particular study. It's one of the most detailed studies I've seen in a number of years. It's very hard-hitting, of course, and it does provide members with opportunities to either to see the big picture in terms of Scotland's health or to pick out individual points to score whatever points we want to do. But I was particularly pleased with the way you introduced the report yourself, Convener, looking back over generations and saying quite clearly that Scotland's health inequalities are a generational issue that successive governments have made some valiant attempts to try to address. What you also said, of course, was that the opportunities to gain are significant financially. And you mentioned the 20 billion or so figure that could be an opportunity to gain. And we do know, and I see from the report, that a simple reduction of 1% in smoking would save 540 lives or so. And we could say the same for alcohol without getting into the alcohol debate, that if we can tackle the consumption of alcohol, we will save thousands of lives and millions of pounds. So with those remarks, what I do see from the Scottish Government's interventions is that there has been a change in policy over in recent years to intervene at an earlier stage. And I do think at this stage, Convener, it's probably too early to assess that, but nevertheless, we have to try. So the question I have for the Auditor General is, and I'm being mindful of the next panel that are coming in front of us, where would you say are the opportunities for greatest gain for us in the system? I know it's a big question and it's quite a wide brush there. Where are the opportunities for greatest gain? Because I would like to put those responses to the next panel when they come before us.
You're right about the very ambitious policies which the government has put forward in terms of public health. This has been a priority for successive governments, but we note somewhere in the report the impact particularly of the smoking ban and the early indications of the changes that's having. So we recognise absolutely the commitment of successive governments to this issue. My sense is that we're now getting to the point where the big initiatives, whether it's policy changes like the smoking ban and minimum pricing for alcohol, like the big programmes such as Keep Well, are probably going to be less effective than really understanding for the particular communities which are the most challenged, what are the barriers that they face, how can the health service help to remove those barriers and provide better support, and how can the health service work with partnerships through the community planning, work with partners in the community planning partnership to work with that more widely around housing, around the environment, around economic development, all of the things that have an impact on the wider determinants of ill health. This is something which is so locally focused and where circumstances tend to be so different that sort of shifting the lens now and looking down at the areas that we know from very good information in Scotland are the ones with the biggest challenges is really important. If I can just draw your attention very briefly to the exhibits 4 and 5 on page 10. People talk about Glasgow's health challenges, and that's true in overall terms. But if you break down Glasgow by ward, first of all, in Exhibit 4, you can see a very wide spread between the least deprived and the most deprived communities and the use of hospital admissions for alcohol and drug misuse. If you then take just one middling ward, Shettleston, and break that down by enumeration districts in the graph below, the spread is actually wider. This is a very localised problem, and understanding where the problems sit and the particular characteristics of them in each area, I think, is the key to the way forward. We've got some of the infrastructure to do that, but we need to really be targeting in at the particular areas.
That's a very... Sorry.
Mr Coffey, could I ask just a wee supplementary to that? Not to decry for a moment public health initiatives on smoking or alcohol, if we can argue about what they should be, but do they or do they not fall into the category of health inputs which lead to a generalised improvement in health but don't necessarily address inequality?
I don't have the detailed evidence at my fingertips, but I'd be very surprised if that wasn't the case. We know that smoking has reduced overall since the smoking ban came in, but we know that it's reduced more quickly among more affluent groups than among more deprived groups.
Sorry, Mr Coffey.
Thanks, Convener, just for that intervention. I'm very grateful for that detailed response again from the Auditor General. I think one of your other clear messages in the report is that we need to be better at tracking the effect of our various interventions. And I think one of the members said that we could spend the same amount of money again and still be none the wiser as to whether that intervention caused that outcome. I think we probably have to do more work in that, and again I'd be obliged to the next panel to give us some better indications of how we can track the spending that we're putting in to try to reduce these health inequalities to see if they're being effective or not.
Thanks very much. Mr Dornan.
Thank you, Convener. Just on the last point you talked about the localisation, I mean, I recognise that from my own constituency. There's certain areas within there that clearly have got greater health inequalities than others. Would you say then that the CPP has a central role to play in this and pulling together all the partners? And further to that, I see that there's going to be a new single outcome agreement which brings in health inequalities. Do you think, can you see that playing an important role in trying to marry the services and make sure we get a greater outcome?
I think that the community planning partnerships, if they're going to fulfil their potential, have to be key to understanding all of the challenges that their area faces and really marshalling the contribution that each of the partners can make, the council, the health board, the other statutory partners, the voluntary sector and communities themselves. And my sense is that needs to start with a really clear and detailed picture of what the challenges are in each area, and then a very concrete plan of action for what money can be contributed, what services bring to bear, how things need to shift to actually tackle the individual problems. I'll ask Claire to pick up in a bit more detail because she's looked at some of these in relation to health inequalities very recently.
What's interesting when you talk to people in a local area and try to get a feel for how the partnerships are working, how they're coming together to do some of the things Caroline's just mentioned, what's interesting is that it starts off in some cases with a bit of a mistrust from some partners, a bit of a, actually for housing, for example, what can we gain from this? And it's almost a case of going through, understanding what each other's business is and seeing where the focus needs to be and the potential improvements for, yes, for the people who are receiving services, but also for the people delivering those services as well. We brought a report on community health partnerships to the committee a little while back, and what came through in that report was the importance of partners working together to understand what it is they were trying to do. And often we found that some very big partnerships actually had missed that very important step right at the start. And that meant, you know, any efforts that came on the back of that were almost ill-focused. They hadn't really understood exactly what it was they were trying to do collectively. So I think that's, again, come through very strongly in this piece of work. Certainly when we've spoken to people at a local level, it's just about a bit of silo mentality, for want of another way of putting it, and people not really seeing the benefits from working together in a more coherent way. And that's not to say just doing it for the good of doing it, but actually being very, very focused on what they're trying to achieve and committed to that, resources, staffing, and keep updating that and checking that it's making a difference. You can't emphasise enough that that was often lacking in some of the local areas we spoke to.
Thanks very much for that. I recognise that. I had I've been to a few CPPs when I was a councillor. One of the concerns for me was that silo mentality where the organisations were looking after themselves as opposed to looking at the big picture. But hopefully this is going to change with the new community empowerment bill, etc. Do you also think accept it, as well as them looking for their vision has to be driven by the public, by the people who live in there? There's no point in the organisations coming in and saying, this is what we see as good for you. That it's got to be, this is what we need, how are you going to be able to help us get it?
And I think the other important thing that I should have mentioned is, as well as the partners understanding their business and what they're about in this case, is actually the engagement with the local people. That's right, the effort and the time that takes to convince people that there can be things that make a difference and that they can trust these people to try and do things that will support them and lead to improvements. You can't overstate the importance of that, and the good partnerships we saw, that's what they tried to do. They'd seen that as very important very early on, and there is evidence that some of that is leading to change, but it's a case of the partners seeing that that's starting to deliver and keeping committed. That point about the short-term focus and the budget's in 1 minute and out the next is another big feature. It is a real long-term investment.
Thanks very much.
Yeah, Mr. Keir.
For the most part, my question was answered. It was basically along the silo mentality and maybe the culture of particularly the health boards, of protecting what they have and not willing to impart information easily. I say that through some degree of experience in local authority. And I was just wondering if there was any major problems in any particular area which highlights a lack of communication. I'm thinking in terms of on page 29, the first quote about practitioners and even managers don't know what CPPs are, and obviously the information that comes from health boards, and then there's the local authority aspect and this silo mentality. Is there any particular area that appears to be worse than others, or is it just a general culture that's embedded in the system?
I think it's generally a difficult problem. Claire talked earlier about the gap you often see between the community planning partnership right across the area and what's happening in a particular GP practice where patients are turning up every day with a range of problems. And how you fill that space in the middle, I think, is not an easy thing to get right. I think there is a real opportunity at the moment to move that forward with the Statement of Ambition for Community Planning that's been published and the more recent guidance, which helps to set very clear expectations for all 32 partnerships about what they should be doing. And what we would love to see is some of this very detailed information about what's happening in the local areas and a dialogue with the people who are providing services locally, thinking about, so what is it we need in this area to help us close that gap for the particular problems that we're focused on trying to tackle.
Is that a problem that is national? There's no one place that's worse than others, though?
We're not able to answer that from this piece of work. We are carrying out some work jointly with the Accounts Commission and myself through Audit Scotland, which is looking at the effectiveness of community planning partnerships, and we'll be briefing you about that work in the new year, I think. So we may be able to give you more of a picture of the effectiveness of partnership working then, but I'm not sure, apart from, as Claire has said, there being wide variation, that there's one place that's got it right or one place which is the problem. It's a much wider variation than that.
That issue of partnerships and how we audit them and hold them to account is a recurring theme, very much so, I think, for the committee. Okay, thank you very much to the Auditor General and our colleagues. We'll now change panels. We're running a bit late, but I think we should still take a 5-minute comfort break. Probably our only one. Committee is reconvened and welcome our second panel. Looking at this report from the Scottish Government, we have Derek Feeley, who's Director General Health and Social Care, Chief Executive of the NHS, Sir Harry Burns, who's the Chief Medical Officer for Scotland, and Donald Henderson, who heads up the Public Health Division. Mr Feeley, would you like to make some introductory remarks?
Thank you, Convener. Briefly. Firstly, we're grateful to the Auditor General and our staff for their helpful analysis of this issue. The Audit Scotland report begins by stating that tackling health inequalities is challenging. I think that underestimates the task. It's probably the most complex problem that we face, and no simple solution. Audit Scotland also recognised that overall health is improving, but I fully accept that inequalities remain a significant and long-standing problem for us. I do agree with the picture presented by Audit Scotland, and I welcome their recognition of the scale and the scope of the challenge. I do regret, however, that the report is relatively narrowly focused thereafter once it does the analysis of the issue. If you look at paragraph 9 of the report, it sets out the focus. And Scottish Government and I think other stakeholders have made some representation at a number of stages of the preliminary work about the importance of the wider determinants of health. And it would be helpful if the Chief Medical Officer was given an opportunity at some point today, Convener, to cover those kind of issues. He can also comment on some of those economic benefit issues that were raised in the earlier evidence session, if that was acceptable to you.
Very happy for Sir Harry to just add to your remarks if you want to.
Okay. Well, let me just cover the rest and then Harry can maybe say something. And you will find, I suspect, again with your permission, that I will defer to Harry more often than I would on almost any other subject matter that the committee might ask us about, because I have the recognised expert in the field alongside me, so there's no point in me trying to second guess what he might say. On the specific recommendations for the Scottish Government that are in the report, a few just very initial comments. There are a range of indicators already in existence that monitor progress in reducing health inequalities, and the most recent publication of those, they're called the Long-Term Monitoring of Health Inequalities. It was published in October 2012. It's an annual report, goes back, I think, to 2009. So, keen to get the committee's view on the adequacy of those indicators and whether there are things to do that we might do to refine and review them, whether they properly give you the picture that you need, but they do exist. I know you're very interested in the distribution of primary care. Our priority to date has been not so much to dictate where practices should be located, but to work with GPs to make sure that the allocation formula and the contractual measures give sufficient priority to deprivation. We're very willing to do more there. We're well engaged with the deep end practices and very keen to continue that dialogue with them. And I also accept there's more that the contract could offer here. That's one reason why we've worked hard recently with the BMA to try and agree with them a more Scottish contract. Community planning, we've got work underway with COSLA to try and enhance that. As you know, the Auditor General referred to the Statement of Ambition and the new guidance that was issued on the 4th of December. It identifies health inequalities as a clear and key priority for single outcome agreements. We're also just about to start, and this is again something we might want to spend some time exploring, about to start a very significant piece of collaborative working right across the public sector, based in community planning partnerships around early years. You may have heard people talk about the Early Years Collaborative, which is aimed at reducing infant mortality, improving attachment and improving readiness to learn. So again, it's a very important piece of work which I think has the potential to make quite a considerable contribution in this area. And then just the final thing to flag up for the committee is that we've reconstituted the Ministerial Task Force on Health Inequalities. And it will consider Audit Scotland's report, obviously the committee's deliberations on that report and their recommendations, and plans itself to issue a report in the summer of 2013. Thank you, Convener.
Okay. Sorry.
Derek, I too welcome anything that shines more light on the issue of health inequalities. I mean, for me, health inequalities are the biggest issue facing Scotland just now, because not only are health inequalities a problem, but health inequalities are really a manifestation of social inequality, social complexity, social disintegration that drives things like criminality, it drives things like poor educational attainment, it drives a whole range of things that we would want to see different in Scotland. So the more attention we can get paid to the drivers of that situation, the better. The unfortunate thing about this report is that if it had come out 20 odd years ago, it would have been really helpful. What it doesn't do is it doesn't pay much attention to the complex science that we now understand underlies the problem of health inequalities. 25 years ago, I was a surgeon in the Royal Infirmary in Glasgow. It was blindingly obvious to me that we were not going to, and the depth and scale of the ill health that we had to deal with was huge. It was very obvious to me that we were not going to fix that problem through attention to conventional risk factors, like smoking and so on, because, as has been mentioned in the report, smoking cessation projects widen health inequalities. Nor were we going to solve the problem through the NHS. There were deep underlying social issues that had to be dealt with. So instead of trying to persuade people to stop smoking and to take exercise and so on, at the time, the next layer of complexity was to say that it was all about locus of control. That was the buzzword at the time. Locus of control meant that affluent people thought that their health decisions were in their own hands. Internal locus of control. The number of times I would speak to patients in the Royal Infirmary say, you really need to give up the booze, or you need to give up the fags. The reply you would get was, if you're going to die, you're going to die. Let's just carry on, We need to, enjoy the time we've got. External locus of control. We then began to think, well, what are the psychological drivers of that? Is it poverty? Is it hopelessness? Is it lack of opportunity? And then as we began to, some of the work I started when I was at the Royal began to show that patients with cancer from affluent and deprived parts of Glasgow responded to their diseases very differently. There were biochemical differences in the way they responded. And that brought in the whole issue of stress responses, inflammatory responses, biochemical drivers. What's going on? It just gets more and more complex. We then began to understand that what happened to people very early on in life were behind some of those changes. And, we'll come back, I think, to the notion of the Early Years Collaborative as a major step change in the way we tackle this. But I was interested, Convener, in your comments about the intergenerational aspects of this, because you're closer to the science than I expect you're aware of, because we now know, astonishingly, that it's possible for the experiences of a grandfather to imprint his genes in ways that are transmittable to sons and grandsons, so that the adverse experiences that people had 50 years ago could still be operative, despite the fact that sons and grandsons are not exposed to those adverse experiences. This is the science of epigenetics, and I can explain that in a bit more detail if you want. So this is an astonishingly complex problem. All these issues are interrelated, and you will not solve them by trying to persuade people to change their behaviours. You need to go to the root of all of this, and the answers are probably multifactorial. If I could comment on the other point that you made at the beginning about the scale of the cost of health inequalities. A few years ago, and in fairness to Audit Scotland, they took the processes used by the Marmot Group a few years ago and prorated them to Scotland. I think the Marmot Group's calculations are wrong. A few years ago, I looked at the economic impact of abolishing inequality in mortality from heart disease and cancer in Scotland, the two biggest killers. I couldn't get the figures to stack up anything like the Marmot Group. Marmot Group based their calculations on work done at the University of Chicago by an economist who eventually won the Nobel Prize for this work. In fact, if you abolish health inequalities from heart disease and cancer, you increase life expectancy by from about 68 to 72 in deprived areas. So people aged 68 are not usually economically active, particularly not in these areas. So the economic benefits that are claimed in the University of Chicago's work don't exist. So the benefits are, I would argue, very much less than the Marmot Group suggested. Having said that, I think health inequalities are an issue of social justice, and we should be doing this because it's the right thing to do, not because of economic benefit. But I think there are issues that I would like to come back to about the way the calculations have been done in terms of benefit of some of the interventions.
Okay, thank you very much. You tempt me down the road of discussing biology that sounded a bit Lamarckian to me, but didn't work for Stalin. But we are the Public Audit Committee, and we do have a ministerial task force which has been first established and then reconvened, as Mr. Feeley said, to address health inequality issues. And in Exhibit 11 in the report, we have elaborated there the Scottish Government spend specifically directed to reduce health inequalities. That covers 3 years, and to my eye, at best, that expenditure is static, and perhaps in real terms it even falls across the 3 years. So if the Ministerial Task Force has been reconvened to address health inequalities, and if this is their own identified funding for addressing these problems, challenging and complex as they are, and these figures include early years and young people, so to a degree, and that does increase over the 3 years, so I think they reflect to some extent the increase in preventative early intervention work. My question is pretty straightforward. Given the report that we have in front of us, given the fact the task force has been reconvened, next year, in next year's budget, is this figure going to increase?
I don't have next year's budget figures in front of me, but we could certainly do
some sense of where the budget in the health service is going at least.
So the health service, the overall health service budget is going to increase. I mean, I think one of the issues in relation to Exhibit 10 and indeed to Exhibit 11, which are our own figures, is what you include and what you exclude. So Exhibit 10, for example, is largely Scottish Government spending on health in the kind of health improvement, public health domain. It doesn't include things like family nurse partnership, which is very much an initiative aimed at improving health inequalities. It doesn't include the QOF payments, which again are in some respect aimed at improving the health inequalities. So there's always an issue about what to include and what to exclude. None of these numbers will reflect the fact that actually much of our health spending is made according to need. And as we heard very clearly from the Auditor General and indeed from Mary SCANLON and others, need is significantly greater in those deprived communities. So in the overall health budget, there will be a significant proportion that's allocated to those deprived communities. We could do the comparative analysis. We could look at what's in these particular allocations and extrapolate them. But I'm not sure it would give us a strong signal about whether we were likely to improve health inequalities or not.
Well, it might not, particularly as part of the evidence of the report, surely, is that although some of the central allocations are made with at least an element of consideration of need, it's not possible to demonstrate how that then translates into the distribution on the ground. So my next question is, if the Scottish Government centrally are making those allocations with that in mind, what do you intend to do to ensure that at a health board and a CHP level, and perhaps even more locally than that, that actually the funds do follow need, as surely the central government intention was when it makes those allocations?
So some of the money is specifically ring-fenced for particular purposes, particularly within the 167 million that's in Exhibit 10. But the totality, much less so. It's for local boards to determine their local priorities. What we are doing increasingly is tracking outcome, and that's how you would make a judgment as to whether the money was being deployed for maximum impact. An example of that is we've had a much clearer focus in our heat targets recently on those, on trying to make sure that there's a kind of proportional investment in areas of deprivation. So we've introduced into our smoking cessation target, into our healthy weight target, etc., specific elements that are about deprived communities. And then you would expect to see the benefits flow through in the longer term indicators. I don't know, Harry, whether you want to.
I would just want to follow up Derek's point about money flowing to need. About 10 years ago, when I was lead clinician for cancer in Scotland, one of the issues that concerned me very much was the fact that deprived women were more likely to die of breast cancer than affluent women with breast cancer. And we thought that that might represent a failure of the health service to distribute treatment equitably. In fact, when we looked at it, we found that the reason deprived women were dying was because they were getting more aggressive cancers, and they were actually getting more treatment than the affluent women. And it comes back, sorry to tempt you back to biology, it comes back to the fact that biologically these women had a different pattern of cancer. And understanding that is something that, you know, I think now, 10 years on, we're beginning to get close to understanding. So as I looked at different outcomes from care, I could not find any evidence that there wasn't appropriate distribution of NHS resource across cancers.
Sorry, I'm struggling slightly with this because the Scottish Government seemed to be presenting two completely contradictory arguments to the committee. The first says that funds are already pursuing need and are being disproportionately spent in areas of greater need in order to drive the outcomes. And the second argument is saying that those kind of measures will have, in fact, no impact whatsoever on health inequalities because they are driven by far more profound and perhaps biological measures. I don't know which argument the Scottish Government is presenting to the committee, and I'd be grateful if we could clarify that.
I am very clear that we will not narrow health inequalities through actions taken by the NHS on its own. It's a pan-societal response that we need. The NHS can be a catalyst for this, but we will not cure health inequalities in that way. We will make some steps in some areas, and heart disease, I think, has been one, which we might come back to, where we're beginning to see the impact of Keep Well. But that's not, the fundamental drivers lie outside the healthcare system, and we need to tackle the fundamental drivers.
And I think that's what we're saying. The health service can and should make a contribution to this, but it will not, in and of itself, completely remove those health inequalities. I would commend to the committee, published in 2007 by Glasgow University, the Medical Research Council there, by Dame Sally McIntyre, Inequalities in Health in Scotland. What are they and what can we do about them? As I say, it was published in 2007, but it remains valid, I think. And Sally identifies 8 or so characteristics of policies likely to be effective in reducing inequalities in health. So about changing the environment, legislative and regulatory controls like smoking bans, fiscal policies like increasing the price of tobacco and alcohol, income support issues, reducing price barriers like free prescriptions and school meals and so on, improving accessibility of services, which I think is the real focus of the Audit Scotland report and the kind of thing that we've been talking about here. Prioritising disadvantaged groups, offering intensive support, starting young, so the kind of early years collaborative family nurse partnership. our contention is you need to do all of those.
Good. Okay.
Can I ask a supplementary?
Yes.
No, it's just a supplementary on that point, Exhibit 11. I note that there is a small increase to harms to health and well-being, more money for alcohol, drugs and violence, and also early years and young people. But health and well-being, including diet, physical activity, health checks and smoking, that budget's been cut. Physical environments and transport that you've just mentioned, Mr Feeley, that budget's been cut by 6 million, and poverty and employment, that budget's been cut by 5 million. So if Sally McIntyre identified these issues in a report 5 years ago, why are you cutting these specific budgets that you've just mentioned?
I can't speak to all of these budget lines. I'm not the accountable officer for all of the budget lines, and I certainly don't have all of the detail. But as I said, what we can do, if it would help the committee, is do the forward comparison of what's in these particular budget lines.
Okay.
Can I come in?
You can.
All right, well, thank you. Sorry, I wonder if I could just seek some clarity on this. I've been off the Health Committee for a while, so I just went to Google to look at what had been done on inequalities recently, and I got a press release 29th of November, and it mentions, as you said, Mr Feeley, that the Ministerial Task Force meets for the first time today. And then I noticed the Work Will Build on Equally Well report of the last Ministerial Task Force in 2008, and I appreciate that they're going to report in 2013. And I do welcome from Paul Wheelhouse, Angela Constance, Derek Mackay, Michael Matheson. I welcome that very much. But has this task force continued to meet since 2008, or was the Ministerial Task Force abandoned in 2008 after Equally Well and met for the first time last week, 4 years later? Or am I reading this wrong?
And he's a member of the task force.
You're absolutely right. The original Ministerial Task Force set up a series of interventions with the purpose of learning what worked and sharing that learning, and it is now a new task force is reconvening to see what has been learned in the past 4 years.
Been a task force since Equally Well 2008.
That's right.
There's been no cross-working ministerial task force for 4 years.
Sorry, could I come in? Actually, there was, before my time in this job, but there was a reconvening in 2010, which my understanding was less fundamental than the original 2008 inquiry, but it is broadly every 2 years that ministers have wanted to look at this area. And in fact, if it hadn't been for the Audit Scotland inquiry, I think we would have kick-started this work probably a bit before the summer rather than a bit after the summer, but we wanted to see where the Audit Scotland work
2008,
was
there's been one meeting of a ministerial task force.
No, there was
in 2010.
No, there was a reconvening of the process in 2010, which I'm afraid we can write to you about the details of that, but
I was a bit surprised to see it met for the first time today, and since the report in 2008, and I thought I must be reading that wrong.
The 2010 reconvening was about making sure that we were pulling together the information and lessons from the 2008 process.
My second question, I had it in mind that there was a target in 2007, whether it was a heat target or not, but I had it in my mind that there was a government target to reduce inequalities. Can I ask, did that exist or did I imagine it?
I don't recall, to be honest.
No.
We've had a we continue to monitor things like inequalities and mortality from heart disease, and one of the things we do is we measure absolute and relative inequalities. In fact, for many of the major killers, mortality has been coming down, but it's been coming down at equal rates in affluent and deprived, so that the inequality in absolute terms has not widened, but because the denominator gets smaller, it widens in relative terms. This is all arithmetical, really, but our aim is to narrow mortality. And in my annual report last year, I called attention to the fact that most of these measures have not narrowed in absolute terms, except there were two I identified last year. One, there was a narrowing in in low birth weight rates between rich and poor, which is I think quite important. Can come back to that. The other, intriguingly, was a narrowing in the rate of first admission for heart disease. And that is now turning into a narrowing in the rate of death from heart disease this year. So we're beginning to see some signs that perhaps Keep Well, which started in, I think, 2006 after the Kerr report, and we predicted it would take 5 to 10 years to see anything happening, it may well be. In fact, we have some evidence that in some practices are doing the Keep Well intervention much more effectively than others, and it may well be that we're beginning to see the scale of that coming to a point where statistically it's maybe having an effect. It's early to say that yet.
Right, can I just go back to what Mr Feeley said, and he said that there is a range of indicators in existence. And having read this report cover to cover, particularly Appendix 3, which looks at all of the strategies aimed at improving health since 2008, so we're talking 4 to 5 years. But within this report, what we have, single outcome agreements do not provide robust evidence of progress in health inequalities. Exhibit 21, community planning partnerships, do not provide robust or consistent evidence. Appendix 3, generally speaking, no evidence of impact to date. These are all government programmes. Keep Well, NHS, not yet determined how to evaluate the long-term impact and cost-effectiveness of Keep Well, I'm quoting from the report. And Equally Well, no evidence that they have reduced inequalities. So, I've spent a fair bit of time reading this report. Everything I've said is a quote from the report, and yet we get Mr Feeley coming along saying, oh, well, there's a range of indicators in existence. So why doesn't Audit Scotland, and why doesn't all of these interventions, why do we have this report, but we don't have the benefit of Mr Feeley's range of indicators, because Audit Scotland couldn't find them?
I think there is a footnote in some page of the report that talks about the long-term indicators. As I say, they were published in October 2012. They cover, you want me to list what they cover?
Well, do they cover everything that I've just listed, there's no information? Healthy
life expectancy at birth, premature mortality, mental well-being, low birth weight, hospital admissions, coronary heart disease deaths, cancer incidents, cancer deaths, alcohol consumption, deaths, all-cause mortality.
Appendix 3 looks at the government interventions, which I think everyone in this Parliament supported. So I would presume that Equally Well, child poverty, road to recovery, achieving our potential, etc. I would presume that you carried out research and you thought, this has got to target inequalities, target deprivation. This has to be a benefit. Therefore, we'll come up with an action plan and a strategy. It comes to this Parliament and lots of money goes into it. And what we have today is little or no evidence. Well, there's the obesity map, no evidence of impact to date. I could go through them all. The road to recovery, 2008, and we're coming up for 5 years since that came out, did not include any information about impact. And we've got, I mentioned earlier, drug-related discharges 16 times higher in the most deprived areas. And what I can't understand is, you come up with action plans, you come up with strategies, you allocate the money, we all support it, we all want this to work, and yet what we have here is no evidence of impact.
I know Harry wants to come in, so I'll defer.
You put your finger on it earlier on, that the history of this effort to narrow health inequalities is full of 3-year projects. It's full of projects that are done piecemeal in different parts of Scotland. At the end of the 3 years, it's evaluated, oh, no difference, we take the money away. This is not something, this has been a tale that's been 50 years in the making. This is not something that's going to change overnight. It's certainly not something that's going to change the Scottish statistics when it's being done, when different things are being done in different parts of Scotland. I would have been astonished if Equally Well, after 3 years, had shown any difference on Scottish statistics. What it does do is it shows that the 7 or 8 test sites have come up with some real learning that, when done at scale across the whole of Scotland, will make a difference. The question I would ask you is there any will politically to do that? Can we begin to say across the whole of Scottish society that at government level, at MSP level, at local authority level, at health board chair and chief executive level, all the way down to the front line, we're all going to do the things that we know have worked in Shettleston and Kirkcaldy and East Lothian and so on, and do it at scale and do it consistently 24/7, because that's what it will take, and it will take stickability. It will take doing it for 5 to 10 years. And then we'll see a difference. I guarantee that.
Well, I don't want to go back, but I mean, certainly for 13 years, public health has not been... it's not been a matter for criticism in this Parliament. Can I just ask you one simple question that I asked earlier? It's maybe not one of the major strategies, but it is nonetheless an important one. What can you do about getting a joined up IT system between a pharmacist and a GP? I mean, in this age and century, with the technology we've got, why does a pharmacist have to print off information, get on his bike and take it to a GP because there's no secure email and there's no incentive to carry out health checks? Can that be overcome?
I'm sure it can be overcome. And we've made considerable progress over recent years in the electronic transmission of, for example, prescriptions. So most of that now is done electronically. So I don't know where this comes from. I will investigate. I'm sure it can be fixed.
Thanks very much. Mr Dornan.
Thank you, Convener. I was interested to hear what Sir Harry was saying about the poverty and hopelessness. Everybody knows that poverty is a driver in this. The hopelessness thing is something I've been saying for some time, and you see it with people you live beside, etc., and people that come in to see you about the fact that they think, oh, well, it's just one of these things. This is what happens when you live in whatever area it is. It concerns me a wee bit as a grandfather that the sins of my youth may well be paid for by my granddaughter and grandson. But what positive steps? I mean, I'm really pleased about the Early Years Collaborative. I think that's a fantastic idea, and I know that long-term benefit. But is there things in place already that means that they don't pay the price for my sins?
The science around this particular epigenetics thing that we're beginning to investigate is by no means clear, but the evidence is that anything like that, we are likely to find some way of reversing it if it proves to be an issue. And we already have some signs in some very localised situations that it has been operative. What I will say to you is your granddaughter won't pay the price because it's inherited down father, son, grandson, and mother, daughter, granddaughter. It's the evidence in this is very much sex segregated. And I'm sure you led a blameless life anyway. But our best bet for this, one of the key drivers of the epigenetic change is lack of nurturing. There's some very, very powerful experimental evidence that shows that failure to nurture offspring lead to changes in the way brain chemicals, particularly brain chemicals associated with positive mood, like serotonin and so on, they are not produced in such great quantities in offspring who are not nurtured effectively. So one of the key things about the Early Years Collaborative is to support parents, young parents who haven't a clue how to handle screaming kids, to show them how to nurture, to relate to them consistently and so on. The experimental evidence on that is very strong. You will reduce things like attention deficit at school, you will improve school attainment, you will improve health, you will deal with a lot of the societal problems. I mean, one of my aspirations for the Early Years Collaborative is that eventually it leads to the closure of Polmont, because there will be fewer young people having to cope with not having learned how to cope, as it were. And so the Early Years Collaborative may well break that cycle if we do it properly, but it will only break the cycle if we do it at scale across the whole of Scotland. Consistency is really important in this, if we're to prove that it works. I believe the time for wee projects is long past. The scientific evidence is quite powerful in a number of areas. Let's apply it and do it. And critically, come back to the point about measurement, measure that it's being delivered. Not measure it with a report 2 years later, but measure it on a day-to-day basis. We did this today to those 10 mums-to-be. We did this yesterday to those 15 mums-to-be. And measure that the interventions being delivered. That's what will turn things around. But the Early Years Collaborative, I think, is the single most important thing we can do. But again, I would caution people to think about a magic bullet. There's no one thing that will make a difference. It's doing it all is important.
Thanks for that. The nurture response encouraged me greatly. As you say, it's not a silver bullet. This takes me back to the point I raised earlier on about the CPPs and the single outcome agreement and about the importance of the community being at the centre of the CPPs. Would you agree that that itself could play quite an important role in making sure that life gets better?
Absolutely. You will know there is a review of community planning underway at the moment, and I've had the opportunity to be at the first 2 meetings, and what I have said to the review, and the minutes are on the website, but I said that we should get in behind action to improve early years, -9 months to 5, and even before the -9 months, you know, we need to be thinking a lot about the health of young girls who may well become pregnant. I would implement a set of actions aimed at reducing offending and reoffending and giving young men who live chaotic lives the opportunity to gain control over their lives and make judgments about the future. We should introduce active labour market programmes. I've had the opportunity to chair a European-funded, Europe-wide project on worklessness and health. And active labour market programmes of the sort that don't just get people off unemployment, but actually teach them life skills as well, seem to be very effective. And we had a really interesting meeting looking at interventions being used in the Roma community in Eastern Europe, a very problematic group, but where things are being turned around very successfully. And then finally, the final thing I'll do to do something across the age range is improve physical activity. People who take 2.5 hours of some kind of exercise a week are much more likely to remain fit into older age. They're much less likely to lose memory. They're much more likely to remain independent and much less likely to fall down and break their hips and so on. So there's a range of interventions that we could implement at scale across Scotland that would change the life course. And they would narrow health inequalities as long as they were done in a sensitive way in deprived areas. And your point earlier on about not doing things to the community, but doing things with the community and helping the community be in control is absolutely critical to this. So yeah, community planning is at the heart of it, but community planning that co-produces outcome with the community doesn't tell the community what to do. We're here to help the community design its own appropriate interventions, and that's one of the big lessons from Equally Well.
Okay, Mr. Scott.
Thank you. I must say I found this utterly compelling this morning. And forgive me, therefore, for asking a couple of, I hope not, completely stupid questions. But is health inequalities or tackling health inequalities, as it were, the #1 NHS/government priority?
It's for me.
Yes, I think I've gathered that. But I wanted...
Is it the #1 government priority? It's certainly one of the, if you look at across the government portfolios, it runs like a thread through them. So that's why it's one of the priorities we've identified for the community planning review. It's why it's on the health's list of priorities. It's the thing that we've, I think, all shared over the last few years, a kind of sense of frustration that we haven't been able to make the progress that we wanted to make. So yeah, it's absolutely right up there.
Do you mind if I ask it the other way around? Is there something that's, forgive me for asking this, is there something that's more important at the moment? Is there something that just is driving your, as it were, inbox every day more than health inequalities?
What drives my inbox is partly what's really important and partly what's really urgent.
Yes, I understand that.
And so the more we can get the health service to deliver the kind of things that it needs to deliver in terms of the quality of care for its patients, and we're making progress there, the more we can get to do that, the more we can focus on these more significant, longer-term, generational kind of issues. But we need to do both.
Indeed, but just on the principle that the convener and the other colleagues were pursuing there, I mean, I very much take your evidence that it's got to be long term. And that politics doesn't help because we're all short term. But are there examples of programmes in this area in tackling health inequalities that were introduced, for example, in 2000 or in the first Parliament, that are still there, that are still running, that are still effective, and therefore have survived the churn of politics?
The one I'm most familiar with was the 2006 Keep Well programme, which fundamentally, instead of doing health checks, the evidence around the cost effectiveness of health checks is very poor. You need to see an awful lot of people in order to deal with one problem. So the aim around Keep Well was to use postcode, a marker of socioeconomic deprivation, to target an enhanced pattern of intervention. And what we've seen emerging from Glasgow, which has had one of the biggest programmes, the most numbers and therefore has gathered the most data, what we've seen is a variation in impact depending on the way the GPs have implemented it. Where the GPs have implemented it, not just the health check, but surrounded it with other bits of things like literacy. I mean, 20% of the patients who attended my clinic at the Royal Infirmary couldn't read the instructions and the drugs that you would give them and so on. So providing that level of support that went along with the intervention has been much more effective than just coming in and saying, right, you need a drug to lower your cholesterol, away you go. So it's about the way you do things. That comes back to the point that what we need as a society to do is to co-produce the outcomes with individuals. Don't do things to them, do things with them. And so helping people take control over their lives in this way is a hallmark of the successful Keep Well practices. So what we have to do is learn where the good outcomes are and make sure it gets spread. And this is what the patient safety programme has been so spectacularly successful in doing. Use that improvement methodology to do it across the whole spectrum, but critically involve local authorities and the broad system in that process.
No, I completely take that, but is it the case that we still have, as it were, too much, how to put this, initiative-itis, that there are too many things that flow at you from, I mean, this is generally not a political point, it must happen under all governments, that government ministers want to make a new approach to an issue and that kind of thing, and you haven't had a series of programmes which have allowed the NHS to really drive this for, well, we're in the 13-year period of devolution.
Derek will want to answer this, but from my point of view, I mean, I've worked in some detail with every health minister since Sam Galbraith, and I can honestly say they all want to do the right thing, irrespective of politics. You know, you might vary slightly in how you might want to do it, but the reality is, and I'm not honestly trying to butter folk up, politicians want to do the right thing. It's a question of, and therefore I have not experienced things being stopped or started willy-nilly. If you've got the evidence that things are moving in the right direction and you have an expectation that they will move in the right direction, people want to get in behind that. So I'm not too negative about it.
It's really reassuring, but it's I guess, therefore, is your argument to us today that we would need to look at this in what period to know that success, or not, I mean, success is probably the wrong word, but some progress or further progress is being made? Is it 10 years away again?
Well, And that's a question I have had to answer. I think the early years collaborative will show a number of changes. The first thing you will see will be a reduction in low birth weight babies. Then you'll see possibly a reduction in things like stillbirth rate, possibly an improvement in infant mortality. You know, you should see that a year from the start of the project, or as soon as it gets scaled up enough to have a statistically significant impact, you will then begin to see infant mortality fall a bit. I wouldn't predict a huge fall in infant mortality. At the 2-year health visitor check, you should see a reduction in developmental delay. So there are intermediate markers that we can see here that will say, well, reduction in developmental delay in the 24-month health visitor assessment will predict a better educational attainment for our children in 5 years' time. So there are markers on the road that will say, yeah, we can be confident that this will happen. But reinforce that this we'll only see this when the number of people involved in the intervention is big enough a proportion of the population of Scotland to get statistical significance. The projectitis, doing it a wee bit here and a wee bit there, will lead to failure because folk will say, oh, this isn't working. It's not working because we don't have enough people in the system to show the statistical benefit.
Can I just briefly add 2 things? Firstly, I think we do need to do a lot of stuff if we're going to make the progress on this. I think so we are going to have to be able to manage a range of connected programmes across the whole of government and across the whole of Scottish civic society. I think the thing which the Early Years Collaborative gives us the opportunity to do is apply a common method across those public services to that big challenge. And the method we've chosen to use is the one that we have been using in patient safety, where it's about getting the reliable application of actually quite common things. It's about doing the common things uncommonly well. Because actually there's quite a lot of evidence in terms of what you should do. It's the challenge has been getting that to happen at scale reliably. And so that's what we're going to try and do in early years. And we'll need to stick at that because that takes a while to stick. The good thing about it is you're counting every day. You're counting as you go along, and the power of the data is not in the kind of, because you start with one, in early years we'll start with one family. And if it works with that one family, we'll do it with 5. If it works with the 5, we'll do it with 25. But you're counting it all the time. And the power of the data is in how regularly you count it as much as in the kind of sample size. So we'll start to get different kind of data that we'll be able to use to gauge our progress as we go along.
Thank you. I think Mr Scanlon has a very short
just a very brief intervention. I mean, Tavi Scott was asking about stopping and starting initiatives. I am aware that up until recently there was no health check between the MMR jab and starting school. So 15 months and 5 years old, 3 3/4 years, nothing. So the 24-month health check has only just been reintroduced. And so maybe we are paying a price for stopping and starting. And I would also say that the impact on the health visiting profession is, do you think that's damaging to the early years?
It's really important we've started it again. And we've started it again because of this. We've started it again specifically because we see it as a step on the road to narrowing health inequalities. And in terms of the health visitors, I love health visitors. I think they're wonderful. They're a hugely important workforce. They do really important things. And the critical thing is to make sure they're organised in a way that gives maximum impact. And that's, you know, at the end of the day, that's up to health boards to take that on.
Checks should never have stopped, really.
I wouldn't disagree with that.
Thank you.
Okay, Mr Griffin.
Thanks, Convener. It was just to pick up on a question on the previous panel and give Mr Feeley perhaps an opportunity to talk about the negotiations with the contract with the BMA and how perhaps the QOF can be targeted more towards tackling some of the inequalities.
So I think there is an opportunity in this. We've started with this deal which we've only just struck in the last week or so. We've started with this to move towards a more Scottish contract. A contract where you pick up the kind of particular Scottish issues, and there are already some things in the new deal that will help us in this agenda. So there's a focus on polypharmacy, which tends to go along with multi-morbidity, which is what you see in these kind of deprived communities. So a stronger focus on that, trying to increase activity around anticipatory care, which again is a key issue in terms of tackling deprivation-related health inequalities is being able to anticipate the issue. So, you know, as I hope we've tried to get over to you, GPs have an important part to play in this, and no one's denying that, but they're not the magic bullet either. But we'll try and make sure as we move forward in those negotiations that we continue to place emphasis on bending the contract in whatever way we can to support our work on inequalities. And we've made a start.
Obviously, it's documented within the report of the effect additional payment had on provision of dentists in the least in the most deprived areas. You can see from 2006 it's almost doubled. Can you see a similar outcome in terms of GP provision in the most deprived areas as a result of any changes to the contract?
So we had a particular issue in dentistry that needed to be fixed, and I'm not sure we have quite the same kind of issue. I was interested in the commentary around the numbers. I'm just trying to find the chart that shows GP numbers. Because I think it is important to recognise that it's not that there's no correlation with GP numbers by deprivation. You know, there's I haven't done the sums, but it looks to me as if there's something like 25 to 30% more GPs in the most deprived area than there is in the least deprived areas. The other things I would say about GP numbers is that there are in total more GPs per head of population in Scotland than any other bit of the UK. If you looked at the distribution of GPs in other bits of the UK, you wouldn't see even that level of correlation in terms of deprivation and numbers. I think, and there are a limited amount of things we can do to require GPs to set up in particular locations. We have been doing some things, and we're continuing to do some things, for example, around the resourcing of new premises. So big investment, for example, coming up in a new health centre in Postle Park, which ought to make that a more attractive place for GPs to do their business. There's definitely more we can and should do in the contract, which we've just discussed, to try and make it more attractive. We've had some success there. Again, if you look at Exhibit 12 in the Audit Scotland report, you see that the deep end practices are tending to do relatively well, and you know, that's something I think we should and could continue. So I think it's something. It's definitely part of the solution. GPs have got an important part to play. We should continue the conversations we've been having with the deep end practices. We've got some initiatives around length of consultation that we're trying to work with them on in terms of whether that would make a difference to the quality of the interaction in the deprived community. We're doing some stuff around the Detect Cancer Early programme that's about trying to understand better why it is that people in deprived areas don't respond, for example, to things like the bowel screening programme as often and regularly as people in less deprived communities. So there's lots of work to do, and we'll keep doing it.
Just coming on that, because I don't think it's necessarily the effectiveness of the intervention is not necessarily driven by the number of GPs, but by the number of people in the primary care team, the extended primary care team that is not necessarily just the GP, because again the evidence from things like Keep Well and Equally Well would suggest that signposting of individuals is very important. It's not the GP that is necessarily going to see someone through a bit of rehabilitation for an alcohol problem, but to have folk who will manage that programme. That doesn't have to be a GP. So my preference would be to say, actually, what's needed in this community in terms of the broad range of skills and invest in that. I think that's what we will likely to see.
Can I we'll come back at the end and follow that point up? I wanted to say to Mr. Feeley, in the commentary around the distribution of GPs in the report, it makes the point that when it comes to whole-time equivalent numbers, there's no whole-time equivalent numbers by deprivation, and I just wondered if there's any possibility of that level of information becoming available.
I mean, we can have a look at that, convener, and if we can construct even some kind of estimate for the committee, we'll do that. Were you going to make the point about people travelling out of area?
Yeah. I mean, I remember when I worked in Glasgow, we looked a bit at this and we found that people in Easterhouse, for example, people in Easterhouse might be signed up with up to 100 different practices spread all around Glasgow, depending on where historically their family came from. So the number of GPs in an area does not necessarily tell you about the number of GPs who are actually seeing patients, if you get my drift. People choose to go...
I do, but we have to work with the data that we have. And the better quality it can be, the better it is. Otherwise, we're in the dark and
But you need to be aware that it might not be completely accurate.
Okay. Ms White.
Thank you very much, Convener. Just good afternoon now, a minute past 12. I think I couldn't agree more with Harry Burns, what he basically said, and I think there's not a great deal of difference between what you said and what the Auditor General said, that Audit Scotland here is about the health, etc., and the money that's been spent, but it's more complex than that. It's deprivation is the actual key. So I don't think there's a great deal of difference. It's just that obviously we're looking at figures and other aspects. And I think in one of my opening remarks earlier, I did say roughly what you'd said, but maybe a wee bit more stronger. But I do think we've got to look at it holistically. I'm interested in the point that was raised about the GPs, and obviously it's a UK-wide, it's negotiated UK-wide, you know, the contracts for GPs. Will we have difficulty with this particular one because it is negotiated UK-wide and it's not just, you know, Scottish-wide? Can you tell me about, I think it's in page 20, paragraph 38, it mentions that changes to the contract are negotiated at a UK level. I just wondered how far we've got down that road and if there be difficulties there.
So what happened this year was that they weren't able to strike a deal at the UK level. And so we entered into negotiations with the BMA in Scotland and reached an agreement with them. There always has been the opportunity to do slightly different things within the UK contract. So the enhanced services look different in England to they do in Scotland, for example. So we've always had some opportunity to flex our approach. We've just taken actually quite a big step, I think, in these latest negotiations to making what's still within a kind of broad UK framework something that's more appropriate to Scotland. So we've maximised the flexibilities that we've got and we'll continue to do that.
Thank you, Convener. I just wanted to clarify that in my own mind as well. I want to just sort of move further on about the more holistic approach. I think everyone's, you know, mentioned that, CPPs, partnership working, etc. Obviously, pharmacies in my area, in Kelvin, we do have a great deal of working with local pharmacies, hospitals and doctors also. So there is, you know, there's an example there that can perhaps be looked at. But I'm interested in the localisations, such as like healthy living centres, that type of thing, but should flow down from the health service and CPPs. But obviously, Glasgow has a particular problem in that area. And I just wondered, as perhaps government spokespersons, whatever it may be, is there any opportunity or would there be any government aspect of looking at you know, more legislation to ensure that we work more holistically between health boards, councils, CHPPs, etc.?
I mean, legislation will take you so far on this, and the Community Empowerment Bill is going through the Parliament, and that ought to help set the right kind of environment. But I think, as you've quite rightly said, some of this is actually just down to the way in which the local people interact, and most of the evidence in terms of what makes good partnership work is around people showing leadership locally. So I think government should set the right kind of environment for that to happen. But in some instances, I think Harry made this point earlier, the right solution is not to do things to people. It's to enable people locally to do things for themselves, so enable and empower them to do things for themselves. And certainly what we've found from what works in some of the equally well pilot sites is that it's those local application of simpler rules make a big difference in those kind of programmes. Is that fair enough, Harry?
Absolutely, absolutely. And the local application, people find very innovative solutions. And it's solutions that you might not immediately, well, I need to be careful what I say here, you might not immediately think were the right solutions when you stand back, but in the situation they are in, they find a way to deal with it, previously intractable problems, by coming up with things that you just never would have anticipated. And that's the power of this co-production. Our role, and by that I mean our role, I think, is to allow an environment for people to co-produce better outcomes. They have part of the solution, and coming together they can create a different dynamic across the community, and too often we get in the way with legislation, or we get in the way with rules and regulations. You know, I've recently had the experience of a community that wanted to take over a disused building. The council, local council, said, no, you can't do that, it's not zoned for that. You know, well, actually change the zoning. It would be my kind of response to that. Too often we get in the way, and our prime role should be to say, what can we do to help that connectedness within communities? And if what we're doing gets in the way of it, we should stop doing it.
I'll leave it there, Chair. I could go on forever, but I'll those other folks want to.
Best not
ask
to, though.
No.
Mr. Coffey, could you go on forever?
Yeah, I certainly won't, Convener. Many thanks for bringing me in there. I think I'd just like to echo Tavish Scott's comments there about how fascinating this discussion is, and I think really for me, Convener, it's certainly lifting my gaze above and beyond the raw statistics that appear in the report. They're very, very helpful, but it's making me think about other issues here, and I'm grateful to Sir Harry Burns and colleagues for doing that. I do have to remind myself sometimes, though, that we are the Audit Committee, we're not the Health Committee, and I'd asked the Auditor General and her team there about the investment that was made in the dental practices since 2007, and the incentive scheme that was brought to bear there, and whether there is an evidence base to show better outcomes in terms of public health in that regard. Could you first of all respond to that, please, and give me any indication of whether there has been?
Go first.
Well,
so there are better outcomes, but there are better outcomes throughout the deprivation deciles, because a number of things that we've been doing, like fluoride vanishing, etc., has made a big difference. But they've made a big difference for everybody. I think the best I can do is offer to write to the committee with whatever evidence exists in terms of what that additional investment has bought. But it's been part of a broader programme to improve dental outcomes in Scotland. So my fear is it will be difficult to just kind of identify cause and effect in terms of the investment that was made, because it's part of a broader improvement programme. Harry might want to add something.
There is a problem with getting the data that would show better dental health in adults, in as much as children, you can dental inspections at schools will tell you the number of decayed, missing and filled teeth that they've got. And the fluoride varnishing was very significant in that, because dentists were never paid to use fluoride varnish, and that has changed, and there has been an impact in most deprived areas. That, together with things like breakfast clubs and so on, helping kids to be better, you have better dental hygiene. Paradoxically, probably the biggest impact of better adult dental health would be on something like heart disease. There is powerful evidence that shows that the chronic inflammation that gets set up by poor dental health has an impact on the arteries. So therefore, it comes back to the complexity of this, is that, we're seeing heart disease fall dramatically. I would be the last person to suggest that that's because of better dental health, but, that may well have something to contribute to it. And you can never unravel this. It comes back to the real complex nature of the drivers of health inequalities.
I'm even more fascinated by that than I was before. Thank you very much for that response. And if there is any evidence or any report on that the impact that's had, I'd certainly appreciate that, as I'm sure the committee would. Another point that Sir Harry made was that I suppose gave me some concern was when you mentioned the incidences of breast cancer within deprived and more often, and it's more aggressive cancers within deprived communities now. I'm no expert, and I would hope to hear from yourself, but what kind of interventions can we make as a society to try to turn that kind of statistic around?
In terms of the more, it's all down to what's technically estrogen receptor positive and estrogen receptor negative cancers. We found that estrogen receptor negative cancers were commoner in women from deprived areas, and that meant that they were more likely to get chemotherapy and radiotherapy, whereas estrogen receptor positive tumours, you could use a particular medication that had less side effects. We puzzled about it, and it looks, the Glasgow Centre for Population Health has published a couple of studies in the past year that shows that, and I'm getting very technical and biological here, I'm sorry about this, but it shows that DNA methylation is different in affluent deprived Glaswegians, and the methylation is a measure essentially of how much damage has been done to DNA, how much DNA has been influenced by adverse environments. And it kind of suggests that there is more likelihood of mutation in people who've had experienced more DNA damage. So we have evidence that says across the social spectrum there is a different level of DNA demethylation. I mean, I'm happy to come back and give you a talk about this if you're really interested, but so it goes to the very basis of the biology of deprivation. It shows that deprivation goes right to the centre of the cell and affects it, which comes back to the fact that simple solutions here are not going to work. We need to do everything at scale that we know will help.
Thanks for that. I just find a very final point, more general point, Sir Harry. I think I can sense your frustration, and what I remember from your contribution is consistency and stickability. Is that the big message that you would give the committee and policymakers, that from this point on, regardless of the messages in the Audit Scotland report, whatever measures you've said, I think on a number of occasions, that do appear to work, make sure we apply them across the board and stick to it, is that that's not been the case in the past, and should that be the policy in the future?
I think it's been too piecemeal. I think across society we need to recognise the scale of the problem, we need to recognise that we're going to do things that are best evidence says work, and we need to build the will to do it across the whole of society, and do it and prove that we're doing it. Get, as Derek says, the day-to-day process measures that show it's happening out there at the front line. And again, not for judgment, but to allow the frontline staff to continually improve what they're doing and learn and develop and support them in that process. Build the will would be the words I would use.
Thanks.
Okay, thanks very much. I just wanted to follow up one thing as we finish, to inform the discussion we'll have later about how we take this forward, bearing in mind, as Mr Coffey said, we are the Audit Committee, not the Health Committee. But in previous work, we have had some engagement with the DPN GPs, that was around the Audit Scotland report and cardiology services, and Mr Coffey and myself met some of the colleagues from DPN and were very struck by the evidence we heard from them. And one of the things which I find quite striking about that is that many of the messages they gave to us, I think, reflected a lot of the things which particularly you, Sir Harry, have said today around fatalism in their patients. This is what happens. We smoke, we drink, we die early. That's how life is. Around comorbidity and the difficulty then of actually getting to the heart of what a particular problem is. Around the importance of non-health interventions to do with housing, income, welfare, and the importance of not just themselves, the GPs, but their wider team, be that anything from health visitors to welfare rights advisors. Is it not still the case that in terms of accessing all of those wider things, for most people, it's still the GP that is the gate, that is the door into that? And their argument was, I think, that they needed more resources and more time to actually undertake some of the work, which I think you've implied is of central importance. Is that reasonable?
It's not unreasonable, but I would come back to the health visitor and the nurse support that you have. I mean, one of the things I learned when I did a lot of breast cancer surgery was that the breast cancer nurse specialist was actually the person that the women would turn to when they had a problem, rather than come to me, and hopefully I was pretty approachable. That the people that individuals in crisis will relate to will differ very much, and therefore we should have a properly staffed team. Yeah, the GPs, and you know, some of the deep end GPs are quite humbling in terms of their commitment to this agenda, and I'm in regular contact with some of them around some of the issues they're dealing with. But I think we should have a diversified economy of people that will help out, and it's this business of who's best to signpost, and sometimes it's the welfare rights, but the nurses are the ones that very often they see as the least threatening.
Thank you very much. Now, a number of colleagues have commented on how compelling the session has been, and with your forbearance I've allowed it to run over a bit on that basis. So thanks very much to Mr Feeley, Mr Henderson and Sir Harry Burns. Thank you. Pause briefly to let the witnesses leave. We're still going to be in public session for those who are getting themselves coffee. No. However, since it's Christmas week on this occasion, Sandra, don't be daft. Right, let's reconvene. Our next item is to look at correspondence from the Scottish Government in response to my letter following our discussion of the report into the NHS financial performance. Paper has been circulated to colleagues. We are running over time, so perhaps I could make a suggestion. I think the correspondence goes some way to answering some of the questions we asked, but it also queries some of the views expressed by Audit Scotland on the transparency of the NHS accounts. I think it would be reasonable to give Audit Scotland the opportunity to in turn respond to that, and my suggestion is that we write to Audit Scotland and ask them to do that in writing for the sake of speed. Is that okay? Agreed?
I have got a question on...
Oh, sorry, Mary. Yes.
No, I just feel that we now have a figure that's being used in debates of backlog maintenance of 1 billion. And...
oh, sorry.
Sorry, we're on...
No, sorry. I didn't realise James wasn't here. My apologies, James. Sorry.
No, I would actually just, I know it's to the Scottish Government, but I would actually find it helpful. I know we've got figures here for minimum risk, significant risk and high risk. And I think we need, you know, what is the definition of high risk, for example? Does it meet health and safety standards? And I think the other thing that we need to know is, I think it was Willie Coffey that mentioned it last time, what surplus assets are included in the figures of background maintenance, because really the 1 billion is not an accurate account, taking into account the surplus assets are included in backlog maintenance. Well, if a building's surplus to requirements and about to be sold, it shouldn't be included in backlog maintenance. And I think we do, as an audit committee, require the definition and indeed how the funding required, the definition of high risk, significant and medium risk. And my understanding is that high risk may not meet health and safety requirements, and I think we just need a bit more clarity on that point.
So,
from Mr. Feeley.
Yes. So I'm suggesting that we write to the Auditor General, ask for our comments on this correspondence. Ms Scanlon is suggesting that we write to the Scottish Government and ask for the definition of high risk, medium risk and low risk.
And also the figure that takes out the surplus assets, because it's my opinion that these should not be included in the figures for backlog maintenance, and then we should hopefully get a more realistic figure.
Can we agree to ask these questions of those two bodies? Okay. Thank you very much. We'll now move into private session, and I will ask members of the public, media, to leave.